Hello and welcome back to the CCS Exam Prep. As you know, there are 4 domains on the CCS exam, and number one, is a doozy. It is the largest portion of the CCS exam, and it focuses on coding knowledge and skills. 51%. The first thing that I want you to lean into is the fact that there are 3 types of records that you should know how to code for the CCS exam. First is going to be inpatient records, inpatient facility, DRG. The second is outpatient. I think sometimes when people hear the word outpatient, they get a little confused. So let me give you some examples of outpatient. Outpatient surgery. An outpatient visit can be considered outpatient, where the patient is coming in to just get some blood drawn, or they're getting, an EKG done. They're getting CT scan, right? That's an outpatient service. And if you have never been to a hospital, I encourage you to go on to a couple of hospitals' websites. Look at the services that they offer that are outpatient in nature. Now, one service that's also a service of the 3 that you need to code is emergency department. So AHEMA splits them into inpatient, outpatient, and then emergency department. And one of the things that I think is so valuable to understand, emergency department coding, as you may know it from an evaluation and management perspective, is different when you're talking about the CCS exam. In your AHEMA CCS exam prep book, one of the things that I want you to notice is the methodology that is used to determine the level, the CPT code, the 99282, 283, 284, those numbers is different for a facility than it is for hospital. In your CPT manual, when you look at the evaluation and management codes, you'll see something like, let's see, total time. Or actually, total time is not for emergency department. Medical decision making is an option, okay? Because total time is not an option for emergency department, because you can be in there forever. But what I want you to understand from a CCS perspective, this is where you got to develop your coder brain. When we're talking about coding for the physician who is seeing the patient in the emergency room department, you're going to follow the rules that are listed in the CPT manual. However, when you are coding for the facility, it's different. The rules are not written in a textbook. They're not written in the CPT manual because the methodology is different. It's based on one of 4 criteria. So I'm not going to talk about that today. I would highly recommend that you conduct some research on that topic, because it is something that you need to know for the CCS exam. And the first thing you want to do is just go look at the emergency department questions in the AHEMA review guide. I had to think about it. And because I could spend an hour talking about facility evaluation and management. So what you want to do is Google facility evaluation and management, and that will give you some links to follow that you can, utilize. All right. So, why did I cover all of that? Number one task for domain number one is apply diagnoses and procedure codes based on the provider's documentation in the health record. Even though we're not billing or coding for the provider, we're still using the information that they put in the medical record. And I know you're thinking like, well, okay, that's so confusing. Okay, let me simplify it for you. I want you to consider a patient who goes to the emergency room and they're seen by an emergency room physician. Okay, and then what happens? In the back, there's all these people who are servicing them. The nurse in the back. There's a nurse up front, right? That the hospital pays. Then there's a nurse in the back that the hospital pays. There's technicians. Technicians that the hospital is paying to do x-rays and labs and EKGs and respiratory therapy and, all the things, right? The hospital is paying all of those people. So when we talk about the documentation, the hospital owns the medical record system. They hire all of the staff. And so if I had to tell you the difference between coding for the doctor versus coding for the facility needs to get paid for all those people who do that work because they're paying their salaries. Those people who do that work, they don't bill the insurance company for their work because they're employees. Whereas the physicians that are seeing the patients, they do bill the insurance company for their evaluation and management services. Now, let's talk about the concept of apply diagnoses and procedure codes. It's so critical that you know your manuals. I cannot overemphasize this enough. I've connected and trained so many individuals that are preparing for the CCS exam. And first question I ask them is, how well do you know your manuals? And they will say, well, what do you mean by that? So here's what I mean. Each manual has a table of contents. Have you gone through the manual to explore all of the contents? There have been individuals that have said to me, I didn't even realize there were diagrams in the back of the diagnoses manual. That tells me that you haven't gotten to know the manual itself. There may be a question on the exam that requires you to utilize a portion of the manual that you don't even know exists. And so you've got to ensure that you do this as a preliminary step. You already know. You got to know the guidelines contained within. You're not memorizing the guidelines. I cannot overemphasize that enough. And just FYI, domain 1 is long, and I'm going to go straight through on this domain. So you might want to pause and get yourself a cup of hot tea, coffee, water, soda, so that you can stay alert during the whole time. And I actually have a cup of hot tea, Earl Grey, my favorite. So, as it pertains to the guidelines, doesn't matter if it's CPT, ICD-10, CM, PCS, this is what you got to know. They each have guidelines. You need to read the guidelines in each book at least 3 times. The first time, you're going to hear me mention this more than once. knowledge, awareness of the guidelines, word for word, line by line. Second, you want to read it the second time for understanding. This part of understanding may require you to pull out other resources, textbooks from any coding courses that you've taken, CPT Assistant, Coding Clinic, okay? And then the third time you're reading for purposes of being able to apply the concepts. So what does that mean, apply the concepts? Given a scenario, you can apply diagnosis and procedure codes based on the documentation in the health record. All right, number 2, determine the principal primary diagnoses and procedure. So now here, what I want you to lean into is that you need to recognize principal is for inpatient. In section 2 of your ICD-10 CM guidelines, you see the principal diagnosis guidelines. From a PCS procedure perspective, there is a principal procedure. That's the last set of rules in the PCS guidelines. Then you have, outpatient. And instead of saying principal, we say primary, meaning the first listed as opposed to secondary. In order to do number 2, you got to do number 1. Whoa, that's huge. All right, number 3, task number 3. Please keep in mind that the content outlines represent the floor of what you are expected to know and not the ceiling. That's so very, very, very important, okay? Apply conventions and guidelines and regulatory guidance. So conventions and guidelines are in the manuals. Regulatory guidance could be something outside of the manual. 3 examples: CPT Assistant, Coding Clinic, information that's on the CMS website, information that's on the OIG's website. As you're preparing for this exam, which is one day of your life, just know that this exam was created to test your knowledge of the typical tasks that a CCS does. So now is the time to really strengthen your skills. Apply CPT HCPCS modifiers to outpatient procedures. Now this is very, very important, so please listen up carefully. In your CPT manual, inside cover on the left side, you see modifiers 22 to 99. Those modifiers are used for your coding for the provider. You're not coding for the provider. You're coding for the hospital. So that particular modifier is not one that you need to know. So you're asking, which ones do I need to know? It's the other ones on the right side that say modifiers for outpatient hospital use. And one of them, as an example, is 27. Appendix A of your CPT manual has those modifiers listed. You want to take the time to read those 3 times. Knowledge, awareness, right? That's number 1. Number 2, understanding. Number 3, application. Next, sequence diagnoses and procedures. So I think one of the things that I recommend in terms of sequencing diagnoses rules, I would pull up an electronic version of the guidelines, CM, PCS to start, and do a search for every time it says sequence. Read it, understand it, be able to apply it. Again, it's not just about this one day. It's about your job as a coding specialist. All right. Number 6, apply present on admission guidelines. So many coders that are in training have said to me, I haven't read the POA guidelines. I know it's Appendix one. And I'm like, but why? Well, because, when I do the practice exercises, it's not something that I have to do, so I really haven't done it. So here's the deal. You got to read the POA guidelines and then understand them and then be able to apply them given a situation. Next, address coding edits. So first, you've taken a reimbursement course, so you have the information at your fingertips. What edits are they talking about? So first, let's pull back and remember that you're coding inpatient, you're coding outpatient. So let's talk about inpatient first. Inpatient, you have the inpatient prospective payment system, right? Medicare has a code editor. What does the editor do? Visualize this. First of all, we're talking about CCS, so you should know the claim form that's used is the UB04 claim form. As the charge master department people are capturing their charges, as you, as the coder, doing soft coding, charge master, hard coding, you, soft coding, as you're doing your coding process, you are putting it into the system. And then at the hospital setting, the claim is going through a scrubber. That's if your hospital has a scrubber. I have done some consulting work for hospitals that, don't have a scrubber. And why? They can't afford to pay for it. So what you put in the system is what goes to the insurance company. Insurance company says yes, no, maybe about paying. Sometimes claims are rejected because they didn't pass an edit. So you as the coder need to be aware of the edits. And guys, this information is on the Medicare website. So inpatient, MCE, Medicare Code Editor. Outpatient, OCE, Outpatient Code Editor. Embedded in the Outpatient Code Editor is the National Correct Coding Initiative. Of note, NCCI has two types of edits: practitioner edits, facility edits. You're coding for the facility. Govern yourself accordingly to those rules, okay? When you start to really lean in and study the concept of coding edits, you'll see that it's things like, the age was wrong based on the CPT code you put in, okay? Do some further research on that. Assign reimbursement classifications. Okay, this is a hospital coder exam, so what do you need to know? Inpatient prospective payment system results in a reimbursement classification of MSDRG. Outpatient prospective payment system results in a classification of APC. Get your domain exam questions for domain 1. Look at what other reimbursement classifications that are discussed in the book. You should be able to recognize that if there is a question that talks about RBRVS, that's when you're coding for the doctor, not the hospital. Again, you got to know your stuff. You have the information, you just got to organize it in your brain. Abstract pertinent data from the health record. I had to take a sip of tea. So when we're talking about abstracting, that means to pull out information. Well, guys, guess what? You need to know the components of the health record. Okay, so what does that mean? Number one, look at these types of questions in your AHIMA review guide in the practice test. I always recommend that everybody look at the content outline before they take that first practice exam, because as you are, once you go through the questions, you're like, whoa, This was domain 2. This was domain 3. Because here's the deal. On the real day of the exam, they're not going to tell you, oh, this is domain 1, task 2. The questions are going to be fired at you one after the other. It is my understanding, and I took the CCS in 2006, but this is my understanding from looking at posts in different groups, you can no longer mark the question and go back. So what does that mean? That means when the question comes on the screen, like right now on the screen it says Coding Knowledge and Skills Part 2, when the question comes on the screen, you have to answer it right then and there. Whoa. Oh, whoa. All right. So what that means is, first of all, you need to know the forms that are in the health records for inpatient, outpatient, emergency. You need to know where to find data on certain forms, because that could be a question. Where would I find the patient's pathology diagnoses, right? So okay, that's all I want to say. Last one, recognize major complication, comorbidity, MCC, and complication and comorbidity, CC. So first thing I want you to check for yourself. Let me give me a sip of tea. Does your ICD-10 PCS, ICD-10 CM, I'm going to start there, CM book say ICD-10 CM for hospitals? If it does not, you have a problem. And that problem is, if you were to be asked a question about CCs or MCCs, not having the ICD-10 CM manual for hospitals is going to present a problem. So this is an area that a lot of folks struggle with for failing to go to the source. So who is the source? Medicare is the source. Medicare has a section of their website that focuses on the MSDRG. It's updated every October. So whenever you're taking your exam, look at the version that would have been effective when the exam was written. The other thing you need to know, you need to practice entering information into an encoder like 3M to determine the MSDRG. This is important because you won't have the encoder on the day of the exam, but you need to have seen the process. And what do I mean by that? If you look at the questions in the review guide, one of the questions that they ask you is like, okay, the patient has these 3 conditions. Which of the conditions will impact the MSDRG? So in order to figure that out, first, you have to identify which of the diagnosis codes is the principal diagnosis and put that code to the side. Then you have to look at the remaining diagnoses from your scenario that would be coded, open up your tabular list, and see which one is a CC or an MCC in order to answer the question. You don't need 3M to do that. However, if you take the time now and enter sample scenarios in 3M, where you're putting in the principal, you're putting in the secondary, you'll get to learn which diagnoses are CCs and MCCs. But you still need the book because it's like 800 of them. And yeah, okay? All right. So I think that's all that I want to cover on this domain. Whoa, this was a long one. But as you can see, lots of information to cover. and you got your work cut out for you. Next up, I'll come back with domain 2.